Okay, I think we can get started. It's my pleasure this afternoon to welcome to today's Grand Rounds discussion Drs. Richard Kummet and Beal Adaskin from the VA. What I'd like to do is share a little bit of background with you regarding the VA's work with the PTSD patients and veterans. The Department of Veterans Affairs operates an internationally recognized network of more than 230 specialized programs for the treatment of PTSD. There are facilities and clinics and more than 90 specialized mental health programs for veterans returning from current and past conflicts. These programs provide a continuum of care from outpatient PTSD, clinical teams through specialized inpatient units, brief treatment units, and residential rehabilitation programs around the country. Every VA medical center, including ours here in Tucson, has a PTSD specialty capability, as do an increasing number of community-based outpatient clinics. So with that background this afternoon, we're going to hear from two of our colleagues from the VA. As I mentioned, Dr. Kummet, who is a 2003 graduate of our residency training program and who has been an outpatient psychiatrist working at the VA treating PTSD patients. Also joining him in the discussion will be Dr. David Beal Adaskin, a former Davis Mountain Mental Health Clinic staff psychologist who also now works at the VA PTSD Mental Health Program. And Dr. Beal Adaskin has provided individual and group outpatient evidence-based treatment including psychotherapy and psychoeducation to a community of 30+ thousand veterans. He has trained and supervised members of the mental health team both in cognitive processing therapy and prolonged exposure therapy for the treatment of PTSD. He is the primary mental health psychologist responsible for training and administering evidence-based therapies for 18 community-based outpatient clinics, their staff, and patients. He also has served as the primary supervisor for trainees participating in PTSD rotations. The title of this afternoon's presentation is PTSD, History, Unique Aspects of Current Veterans Treatment and Evidence-Based CBT Exposure-Based Therapies. So we'll first start with Dr. Kummet.
There are a couple of seats left down in the front in case anybody wants to move up. Thank you very much for having me come today. I graduated from this residency program, as John mentioned, and the last time I was standing here is when I gave my Grand Rounds presentation as a fourth-year resident. So I'm experiencing a little bit of PTSD myself, but I'll work through it with the exposure therapy that I've been doing with Dr. Beal. I'm going to go for about 20-25 minutes, and then I'm going to turn it over to Dr. Beal. And I'm going to talk with you about some background about PTSD, the evolution of the PTSD concept over time, features of PTSD, and some information about the global war on terror and treatment about PTSD. I'll be talking about pharmacotherapy, and Dr. Beal is going to be talking with you about psychotherapy. And then we'll open it up for questions. And by no means is this a comprehensive presentation about PTSD, given the limited amount of time that we have, and the scope of the talk is fairly broad. Again, this is not meant to be comprehensive. That would really take several hours to have a good comprehensive presentation about PTSD, and even that wouldn't really be sufficient. So there's several historical timelines for the evolution of PTSD over time. The first is the observation of symptoms of PTSD through history, and then there's another timeline, the recognition by the United States of actually a connection between combat and what we now know to be PTSD. And the third timeline involves the DSM and the attention that it's given to the concept of PTSD. Features of PTSD are first described in literature by Homer's Iliad and the Odyssey. Hippocrates was one of the first, if not the first, to feel that madness could actually be caused by a diseased brain as opposed to direct intervention by gods. During the Civil War, what we now know to be PTSD was described as soldier's heart, irritable heart, or sunstroke. In World War I, the term shell shock was used, and the symptoms of PTSD were believed to be completely related to actual physical disruption of the brain related to artillery blast. The observation was made that treating PTSD was extremely expensive, and there were debates about service-connected disability, and it was noted that the field was drained of soldiers when attention was paid to PTSD. In this context, in 1916, there was a War Congress which was held in Munich with the world's leading neurologists and psychiatrists, and they determined that shell shock could only occur in soldiers with hysteria, a pre-existing personality weakness. Hysteria was used. It was a very stigmatizing term by design, and this view of the issue was adopted by the United States and most of the rest of the world. In World War II, the Korean War, and the Vietnam War, we were using a demedicalized hysteria model. We had very low rates of wartime psychiatric evacuations and massive attempts to screen out the mentally vulnerable soldiers failed to prevent long-term disability, which we know with Vietnam. Now we move to Iraq, Afghanistan, and the larger global war on terror. Some abbreviations that we commonly use at the VA that you may or may not be familiar with is OIF, which is Operation Iraqi Freedom, OEF, which is Operation Enduring Freedom, and that relates to Afghanistan. 1.7 million United States troops have served in these wars since 2002. And currently we're seeing more eligible separated veterans accessing VA care than we've seen in the past. About 45% of eligible veterans, or 454,000, have sought care between 2002 and the second quarter of 2009. And that is related to a number of factors. I think it's kind of not your father's VA anymore. We've tried to be more sensitive to the needs of veterans. We've recently increased the eligibility for veterans from 2 years post-discharge to 5 years post-discharge, where we'll basically see them for just about anything. And there's an exemption of copay for any illness that may be related to deployment. And there's been aggressive and extensive outreach programs to veterans that have recently separated. This is one of our programs, the OIF Transition Program. This is an event, what we call a Welcome Home event, that we held at Tucson Electric Park last year, and we're going to be doing another one this coming year in October of 2010 on the U of A Mall. We're hoping that we might be able to hit a few more veterans. There's actually about 600 to 800 veterans that are students at the University of Arizona right now. So there are some unique characteristics of OIF, OEF veterans. As we all know, there's greater use of National Guard and Reserve forces, about 50-50, versus active duty. Soldiers have multiple deployments. About 40% of the approximately 10,000 veterans that we see here in Tucson have had multiple deployments, and we're clearly seeing larger numbers of women serving. And something else that's very notable is the length of the conflict. At this point, the length of this conflict is almost 2 times the amount of time that the United States spent actively involved in World War II. Women veterans, approximately 120 women have been killed, 650 women have been wounded, and though barred from direct combat, women do serve in dangerous positions. Unfortunately, there are very high rates of military sexual assault, and we have a specialized clinic at the Tucson VA in dealing with this issue. There's high rates of divorce, high rates of being single parents, of course, and a much more limited social support system when women combat veterans return home versus their male counterparts who often have war buddies. And that same type of culture doesn't really exist among women. Millennium Cohort Study was an ongoing study, or is an ongoing study, of about 55,000 military personnel. It's sponsored by the Department of Defense. And we find that about 8.7% of those with combat deployments have PTSD versus about 2.1% of those with non-combat deployments. And interestingly, about 3%, a little higher number, of those who are non-deployed will have PTSD. And we could argue why that's the case. Perhaps some artificial selection there, I'm not sure. We have increased PTSD with prior assault. So if you've had a history of assault prior to being involved in combat, you have higher rates of PTSD, which is not surprising. A short one slide on traumatic brain injury. That's if there is a condition that's really going to be known with this conflict, it's going to be traumatic brain injury. This current conflict has the highest wounded to kill ratio in history of any conflict. Global war and terror, 10 soldiers wounded for every soldier that's killed. In Vietnam, that ratio is 2.8. In Korea, it was about the same. In World War II, it was less than 2. What that means is that we're seeing a lot of people coming back who are injured, often with traumatic brain injury, that wouldn't have survived in the past. Now on to the history of PTSD as a diagnosis. In 1896, Kraepelin, if I'm pronouncing that correctly, used the term fright neurosis to describe what we now know to be PTSD. Gross stress reactions was a term used by the DSM in 1952, and then transient situational disturbances in 1968. In 1980, we had the DSM-3, which was published, and for the first time, PTSD was recognized as a formal diagnostic category unto itself. And for the first time, symptoms were actually attributed causally to trauma. And trauma was defined as that is outside the range of usual human experience. This is something that changed with DSM-4, where we have the current criteria, and I'm not going to go through those because we probably know them pretty well. 3 symptom clusters: intrusive thoughts, arousal symptoms, and avoidance symptoms. And it broadened the definition to more than just events which were beyond normal experience. It also included secondary traumatic exposure, which is controversial among some. And of course, symptoms must cause clinically significant functional impairment. In 1994, we also added acute stress disorder, which describes less severe symptomatology. And evidence seems to point that people that have acute stress disorder are at higher likelihood for developing PTSD. And the next step is going to be the DSM-5, which is going to be published in 2013. And currently, the definitions, the criteria, are available online. I think it's dsm5.org, although I'm not sure. It's something like that. If you Google it, you can find it, and you can review all of the different criteria. And some changes have been made. One of the big ones is that learning that a traumatic event to a close relative or a close friend is going to be a criteria, at least this is under review, and experiencing repeated or extreme exposure to aversive details of the event with an exclusion for experience being through electronic media. Oh, and I do have the website here, dsm5.org. I'm not sure if you guys can make that out. But it's interesting to go through to see how some of the diagnoses that we've been using for quite a while are going to be changing. Also, a 4th criteria set was added. We have the usual that we're used to: intrusive avoidance and arousal symptoms, but in addition, negative alterations in cognitions and mood that are associated with the traumatic events that began or worsened after the traumatic event, and there's a list of those here. PTSD is common. It affects about 8% of the United States population, though about 90% experience trauma. So there's clearly nowhere near a one-to-one correlation. It's more common among women, and it's more common among those who have had adverse childhood experiences, various forms of childhood trauma. Deployed military personnel are more likely to have PTSD, especially those who served in Vietnam. Treatment of PTSD is multifaceted. My area of expertise is pharmacotherapy, and that's what I'll talk with you about. And Dr. Beal, again, will talk with you about various forms of psychotherapy that are evidence-based to be effective in treating post-traumatic stress disorder. Pharmacotherapy is effective, and it can treat some of the comorbid disorders associated with PTSD, and it's readily accepted by most patients, though not all. And it's easily used by any prescriber versus psychotherapy, which takes a very well-trained therapist to carry out some of the therapies that Dr. Beal will talk with you about. Sometimes that's difficult to find, so we're fortunate to have Dr. Beal on staff. Here is a list of the SSRIs. All of these can be used for the treatment of PTSD. We have the strongest data for Paxil, Zoloft, and fluoxetine. And SSRIs are clearly recommended as first-line treatment for PTSD. I don't think that there's really any question about that. There may be some question about the use of SSRIs in the treatment of combat-related PTSD, but I don't know that we have, pharmacotherapy-wise, I don't know that we have anything that's a whole lot better. In 2009, the APA guidelines were amended a little bit, and they said the following: the 2004 guideline recommends the SSRIs as a first-line treatment for patients with PTSD. However, trials reviewed show that SSRIs may no longer be recommended with the same level of confidence for patients with combat-related PTSD. So with SSRIs, we start with a low dose, increase slowly as we would for other anxiety disorders, so that patients aren't scared off by the potential side effects. And an adequate trial is, of course, 6 to 12 weeks. SNRIs have shown improvement in PTSD symptoms, not so much for hyperarousal. Wellbutrin has had a negative study. This is what I was aware of in the literature. 30 patients with civilian or military-related PTSD were randomly assigned to placebo or bupropion. And again, this was a negative study. Half these patients were already receiving an SSRI at the time of randomization. So that may point to the fact that SSRIs are more effective than the bupropion. Mirtazapine is one of the antidepressants that we use that's kind of in a class by itself. In a double-blind, randomized, placebo-controlled trial with a small number of patients, 29, it was found to be more effective than placebo. Antidepressants in general are equally as effective as each other in a few head-to-head studies that have been done, and there's usually improvement versus placebo. So back to the antidepressants, primarily SSRIs is what we're talking about. There's not overwhelming evidence. There's nothing to get really excited about and shout from the rooftops, but at this point, I would say that it is the standard of care to at least trial an SSRI with patients that have PTSD. Again, less strong evidence for combat-related PTSD. Benzodiazepines can be effective for insomnia and anxiety, which are some of the core symptoms of PTSD. Unfortunately, symptoms can worsen in the long term with benzodiazepines. Benzodiazepines interfere with the cognitive processing of trauma that will often lead to desensitization. And when you refer a patient on benzodiazepines to somebody like Dr. Beal, who's going to be doing exposure therapy, they don't want the patients to be on benzodiazepines. You actually want to elicit that anxiety reaction. Benzodiazepines should clearly not be used as monotherapy, and they shouldn't be used long-term. Some evidence supporting the use of second-generation antipsychotics. I would say that quetiapine probably leads the way. Quetiapine can be helpful for nightmares, and there have been 2 open trials which suggest some efficacy. There have been some trials that support the use of risperidone. There have been negative trials for anticonvulsant medications. There's been some research done on immediate adrenergic blockade. 2 small studies have shown that propranolol might be of help in reducing the severity of PTSD when it's given immediately, within hours after a traumatic event. So a large dose for a short period of time. We really need more research to see if this is going to be borne out in larger trials, but it certainly is an interesting area to take a look at. In 2007, there was a study with propranolol compared to Neurontin or gabapentin, which was used in that manner, and it was a negative study. There's also been some study of opiates in the same way. And here's some data about a study that was done with the opiates, and there were actually lower rates of PTSD among those that were treated with morphine, and that it was not dose-dependent. There may be an adrenergic blocking effect of the morphine, and also the effect could be related to the analgesia and maybe memory formation in the context of using the opiates. Sleep is very important in the treatment of PTSD. It's very disrupted in most patients, in my experience, that have PTSD, as far as disruptions of the sleep, both without nightmares and often with nightmares. It's important to assess sleep hygiene and have a discussion with the patient about good sleep hygiene. It's important to screen for obstructive sleep apnea, which I do frequently. Trazodone can be used, but it can increase nightmares. Quetiapine, as I mentioned before, is often used, and it actually has inherent alpha-1 blocking effects, and I'll talk about prazosin in a moment. So it kind of works like prazosin in that way, which is a very effective treatment for nightmares. Benzodiazepines, as I mentioned before, is not a great treatment for PTSD. One slide just to clarify what nightmares are. True nightmares cause awakening. They evoke strong negative emotions such as fear, anger, and sadness, and are recalled in detail. And it can make it difficult for the patient to fall back asleep again, often because they have a fear that they're going to have nightmares again. Prazosin is one of the most effective treatments that we have for PTSD, and it's effective at treating primarily one symptom, which is nightmares. What I do is I start with a very low dose, 1 or 2 milligrams at night, and every couple of days I'll increase the dose. And I have some patients up to 12 and 14 milligrams of prazosin at night, and this is probably the one medication that I've used that I've had the best results from, really in anything that I've treated, certainly PTSD. And unfortunately, since I made this slide, there's been an issue with the availability of prazosin, which you may or may not be aware of. The manufacturer has had difficulty keeping up with the demand for prazosin. So prazosin is actually hard to come by now, which is very unfortunate because it's inexpensive, it has a very good side effect profile, and it works very well. At the VA, we're only giving 30-day supplies of it because, again, it's hard to get a hold of. I'm going to step on David's toes just for a second. I want to mention image rehearsal therapy. It's a specific therapy for nightmares. In it, the patient fully describes the recurrent nightmare and then kind of rewrites it repeatedly and fully engages in going over that new script, and this is something where there is some good evidence for efficacy. And now I will turn it over to Dr. Beal.
Well, Dr. Kumit started by talking about his own PTSD, so I'll talk about mine. The last time I was told by our camera crew I had to stand behind the podium so I could be on the camera at all times. The last time I had to do this, I was in the military in full service dress, and I had to stand at attention for 20 minutes. So if I start wigging out on y'all, just show me some mercy. I'm going to, like Dr. Kumit said, I'm going to be talking about specifically psychotherapy and the treatments, evidence-based treatments that we use at the VA, and the treatments that are also being used in the DoD, DoD-wide right now. And those two therapies right now that have the most empirical support are prolonged exposure therapy and cognitive processing therapy. There are other treatments that people will use and they can be certified in. I don't know if some of you have heard of EMDR. The main reason why the VA and the DoD won't recognize that, it's not that they won't recognize it. If people are trained in it, they'll allow you to use it. They won't support it financially in terms of training and supervision and things of that nature. Some of the early literature on that would suggest that it's actually the exposure component that's effective. And so what they're requiring is the researchers to kind of pull it out and do a separate study, a dismantling study with just eye movement to see if that contributes to significant results. So it's not that it will cause harm, it's actually shown to be effective. But until some further studies are done, the DoD and the VA aren't training people in it right now. Social skills training, what that is we actually incorporate that in the VA. I did a little bit of it when I was active duty as well. That's sort of like helping people with symptom management. It's probably not going to help the PTSD go away, but will help them function a little bit better in society. ACT is acceptance and commitment therapy, has not been proven to be effective in PTSD. They use it a lot for depression. Some people will use it for anxiety as well. Again, it doesn't have enough empirical support that will use it specifically for PTSD. Supportive counseling, I put some question marks there. We did a little survey while I was active duty, and it showed that about 25 to 30% of the providers in the military were trained in using PE or CPT, and so we asked, what are the other 70 to 75% using, and most of them were using supportive counseling. There's some data coming back that saying not only is that not helpful for PTSD, but can almost be harmful in the sense that people are coming and thinking that they're going to get some help and get some benefit in their symptoms, and really what the nature of supportive counseling is not to push people too hard. And exposure therapy pushes people, and so it's almost in the sense that the provider can be colluding with the patient's avoidance by not ever having them talk about the trauma. So if you're trained in supportive counseling, I would recommend at this point probably not using it because, again, we don't have good conclusive data that it's helpful, and actually with some people can be harmful because they're coming to you, but their symptoms are still being maintained on some level because they're not getting to the core of what's driving the symptomology. Prolonged exposure and CPT are cognitive behavioral therapies. Prolonged exposure is more behaviorally based, and cognitive processing therapy is more cognitively based, but they both fit into that CBT camp. Tons of empirical support for both therapies. Prolonged exposure probably has the most behind it in terms of a treatment that I've seen in disorder. So it's pretty robust. A lot of different studies and a lot more to come. Big grants have been awarded by the government to researchers that are now taking these therapies overseas, and we're starting to look at the effects of it in the combat zone as well. So it's pretty exciting to see what's going to be coming back in the next few years. PE was initially started with sexual assault victims and was shown to be effective, and since that time has been used with combat vets, and the data is pretty consistent in terms of benefit of this treatment. One of the things that we're seeing at the VA, though, is that with combat trauma, it can be a little bit more complex versus, say, a one-time incident relating to PTSD, just because of the repetitive nature of the fear arousal. I'll talk a little bit about how that fear mechanism works in the brain. That's tapped into a little bit more frequently when you're deployed for a year straight versus being exposed to a one-time incident. So it can be a little bit more complex with the combat vets. And so what the fear structure, what we're talking about when we mention that is essentially there's representations of stimuli and responses that we have and meaning we attach to it when we encounter a situation where our life or our safety is in danger. And this gets mapped onto the brain. The hippocampus, as part of the memory, will store information that we have close attachment to, or that is significant to us. So you can imagine, well, I don't know if you can imagine, but if you can possibly imagine what it's like to be having mortars and things going off around you or getting held at gunpoint, that's probably going to be etched in your brain pretty clearly. You're going to have a pretty good memory of that when it's happening. And that's also eliciting a fear response in the brain, as it should. It's a survival mechanism. Third grade biology, fight, flight, or freeze response. Okay, that's essentially what we're talking about. And so our body reacts the way it should, to protect ourselves. And so the theory behind this is that as this gets tapped into more and more, there's other stimuli that people are taking in as well that in and of themselves are probably fairly innocent, but they get mapped on the brain. And so when people are out of those situations, if they encounter those start triggering the same responses that they would have if they were in life-threatening situations. And that's the primary maintenance factor of PTSD and how it's working for people. And so in terms of pathology, that's not a term I like to use a lot with my vets. We don't like to pathologize their condition. Kind of the way we look at it is that it's, PTSD isn't a characterological problem like they hypothesized in, early 1900s, late 1800s. Kind of how we look at it now is that it's a problem in recovery. These reactions that people have that are exposed to trauma are normal, but they're normal reactions to abnormal events. However, that being said, their associations between the stimuli don't always accurately reflect the world or what is actually a realistic threat. So for instance, I don't know if you all remember what Dr. Kummet was wearing, but he's got a blue shirt and an orange tie and gray slacks. It just pummels me really bad and puts me in the hospital and causes a bunch of injuries. I might have a traumatic reaction to that. Most likely I probably would. Whether or not I develop PTSD is another story, but let's just say for the sake of argument I do. What do you think is going to happen, say 3 weeks, 4 weeks later when I walk down the street and I see a 5'8" Caucasian guy with glasses with an orange tie and a blue shirt? That fear response is probably going to get evoked in me. Now, I may not be in danger at all. He might walk by me, but I'm going to respond as if I am in danger. And so that's where my associations aren't really accurately reflecting the level of danger, the level of risk that I'm in. And that's the problem with folks with PTSD. Really, they have an overactive amygdala. It's kind of taken the frontal lobe hostage, and it becomes very difficult for folks with PTSD to navigate that territory and to kind of modulate that overactive amygdala. So they're responding to all kinds of stimuli. Even those stimuli that are, say, 2 or 3 on a 0 to 10 scale, they're responding like on a 9 or 10 level. And so what do they start to do? They start to avoid stuff. I might actually start to look for people that look like him and make sure that I steer clear of them because, in my brain, I'm going to be at risk here. I can be harmed. So people will start to actively avoid things. So if you can think of a scope where you have this, like a huge box of your experience, and all of a sudden, okay, well, I can't go there and I can't do that anymore, and your box starts shrinking. And then you encounter something else and you start having those responses. And, okay, I can't do that anymore. And the next thing you know, we see this a lot in our Vietnam vets who have had PTSD for 30, 40 years. The box shrinks to where it's about this big, and you don't have a whole bunch of experiences that you can encounter and you can engage in where that stimuli is not getting evoked. And so it starts to interfere big time with your normal routines and your normal behaviors. So what brings a lot of our vets in is, well, my spouse told me to come in, because they won't even go out to dinner anymore. They're fearful of crowds because they can't watch everybody. And so they won't do that. And God forbid if their spouse or significant other asks them to stop at the store at 5 o'clock. It's usually Walmart. Do you get Walmart a lot? Nobody will go to Walmart at 5 o'clock, or God forbid on a Saturday, right? No way. So they'll say, oh, I'm not going to do it. I'll go at 2 in the morning. Well, that can be pretty inconvenient if you got a sick kid and you need some medicine. So this stuff really starts to interfere with daily living, and that's what really makes it a problem for a lot of folks, because you can't avoid everything. Yeah, I do. I don't have PTSD, but I won't even go there. So we can empathize with our vets a little bit when they tell us that. And then this bottom bullet, it really kind of sums it up. It's just a lot of harmless stimuli that just interfere with their day-to-day living. A large crowd on a street in Baghdad means a heck of a lot more than it does a large crowd, say, at Tucson Mall. Okay, we can understand that. That's very hard. And there's a lot of vets that say, yeah, I get that up here, but again, their body's just reacting and they're going into defense mode because it's consistent with how they've been trained and how they've responded. So what we try to do in the therapy, it's an exposure-based therapy, we expose them, get them anxious so they can experience that anxiety and their body naturally comes down. They start to become habituated to this. It becomes easier. And through that process, they can start to associate, all right, this stimulus isn't as threatening as I thought it was. It's good in theory. It's very difficult in practice. It works. But it's very difficult to sell this to folks with PTSD, especially folks with chronic PTSD, and I'm not saying chronic by the DSM definition of over 6 months. We're talking about years and decades here. They've developed this behavioral pattern of avoidance. It's very difficult to reverse. So how we do that exposure is in 2 components. One is called in vivo exposure, which is very big with panic disorder and all kinds of other anxiety disorders. You're probably familiar with it. And it's basically just systematically confronting situations that lead to real-life anxiety. So for instance, vets will say, well, I won't go to eat, I won't go in a restaurant, I won't go to Walmart, won't go to the movies. So we just create a hierarchy for them, and we rank it based on their subjective units of distress, so how much distress they would feel in a situation. Rack and stack it from 0 to 100, and we typically start working on items that are about 30 or 40, and systematically working closer to those things that are more anxiety producing. And again, the more they do it, the easier it gets, and it leads to habituation, and they can start reclaiming their life back. These are not things that are inherently dangerous, okay? So I had a client who got hit by a car, developed PTSD. We actually decided not to have him go back to the scene of the accident because he was changing his tire on the side of the I-10. I wouldn't do that. I'm certainly not going to ask my patients to do it. That's not a safe thing to do. These are all inherently safe things that they perceive as being unsafe. So it's stopping at a Circle K on the way home. It's going to a movie at 7 o'clock at night on a Friday when it's a new release. These are the kind of things that we're on a hierarchy that we ask them to do. The other part is imaginal exposure, and that's where they will review their memory repeatedly, over and over. And so for people with multiple traumas, we typically select, there's a little bit different than in vivo, we typically select the memory that elicits the most anxiety, because then the habituation effect tends to generalize to the other memories. Okay? And that's where they will come in and they'll go through their memory repeatedly, probably for about 45 minutes. They get to experience all the emotion and all the thoughts that they kind of boxed up and put away, process them, and then, again, the idea is there's habituation. They start to experience some cognitive changes. They start to view the situation a little bit differently. They can see things through a different set of eyes. And then when they do remember it, because they will, there's nothing we can do to help them forget except for frontal lobotomy. And I'm not credentialed to do that. And I don't want a bunch of people looking like McMurtry in One Flew Over the Cuckoo's Nest. So we opt for this, a little bit less invasive. And by doing this procedure, when the memories do come back, they're a lot less anxiety provoking for the patients. Sessions are for prolonged exposure right now. They are individual, and they're about 9 to 12, and they work 90 minutes. You can see people once a week or twice a week. We recommend that you don't stretch it out more than that to see, say, every month or every 3 weeks, because you just lose a lot of momentum. Especially the first time they come in, they do an exposure. It's very important to get them back in quickly, so as not to reinforce that avoidance, because it would be very easy for them, go home and listen to the tapes. They need to listen to the tapes as part of their homework and keep up with that stuff. So we try to get them in once a week, if not twice a week, to do that. And the homework can be pretty intensive, so this is a hard sell for people working full-time. But fortunately, for a lot of our vets that have been diagnosed with PTSD that are getting some kind of compensation and are not back in a full-time job, this is something that they can do pretty easily. CPT is also a cognitive behavioral treatment. Like I said, it's a little bit more cognitively based. Again, has a lot of empirical support. It was developed by VA researchers out of Boston. And it also uses the same theory behind it as prolonged exposure, so I'm not going to get into that. Essentially, what we're looking at is the person's view of the event and how they're coping with it. So how they perceive the event. Okay, and typically what people will do is they will do one of two things when a traumatic event happens. It will either reinforce pre-existing beliefs for them, or it will completely change their beliefs. So if someone grew up in a pretty stable home, not a lot of trauma, and they basically believe that the world's a pretty safe place, they'll encounter a traumatic event, and their belief will probably completely shift to the world's unsafe. Okay? Folks that grew up in a relatively unsafe environment will encounter a traumatic situation, and that belief will be reinforced. They'll say, see more evidence for that. So what cognitive processing therapy sets up to do is to look at not only the event in detail, but pays a little bit more attention to their perceptions of it and how their cognitions have changed as a result. So we use a bunch of therapy techniques to make that happen. The first is to have them write the trauma. We don't verbalize it, we write it, and then they will read it to you in session. But they don't review it as often as you do in prolonged exposure therapy. And the researchers that developed this, their theory was that you don't have to go through something repeatedly to have some habituation of the event, okay? So there's a little bit of a difference in theory there, but it's still exposure-based in the sense that people are writing about their trauma and reviewing it with the therapist. We use ABC sheets, which are common for cognitive therapy in terms of looking at how events impact people's thoughts and then the subsequent emotions and behaviors that are associated with it. So once we get through the trauma account, we can identify what a lot of people's core beliefs are. We can start working on that with them and challenging some of those beliefs. And those beliefs typically fall in the 5 modules which are listed there. And so a lot of the time in therapy is spent going over how the event that happened, 3 years ago or 30 years ago has impacted them today in these areas of safety, trust, power, control, esteem, and intimacy. This session structure is, again, it's time limited, like prolonged exposure, which is a great patients, that they know that they can come in and within about 3 months they can get through treatment if they come once a week. Right now our groups, we said 60 to 90 minutes. The one-on-one sessions are 60. We do groups that are 90. Those group sessions are a little bit longer because it just takes longer to get through the traumatic events and the worksheets when you have more people in the group. So those can go anywhere from 15 to sometimes 18 sessions depending on the makeup of the group. But again, if you're meeting once a week, you'll be able to get through this in 3 or 4 months. That's pretty good. So we get a lot of disbelief when people first come in. They say, I've been dealing with this 30, 40 years. How are you going to help me in 3 or 4 months? But we've got, a lot of good evidence that shows the efficacy of these treatments. Depending on the literature that you look at, anywhere from 70 to 80 to 85% of the people that do these treatments get better. Big reason why a lot don't is either due to attrition, where they're dropping out, or they're not fully compliant with all the aspects of the therapy. Okay, and you can imagine why that would be. I mean, you've got people that have developed some good avoidance mechanisms. All the homework we do is designed to get them to look closely either at the trauma or the effects of the trauma. So they can be pretty resistant to that, even if they're generally not resistant people. Again, because we're eliciting that anxiety response, and that can be difficult. So we see a real close correlation in the VA, the amount of people that put in the effort and do everything with treatment outcome. Okay, that hasn't been backed up completely in all the literature at this point, but that's what we're seeing at the VA, and I saw the same thing in the DoD. So some contraindications, as Dr. Kumit said, the benzodiazepines interfere with frontal lobe functioning, so we really don't like it in CPT because it's very cognitively based and it really puts people at a handicap, especially if people are on high doses. We've had some people come to sessions and they've, for lack of better words, really been doped up, and they can't even track with the material, let alone be able to sit back and reflect on their own thinking. From an anxiety response, a lot of benzos are quick hitters, so when we're trying to get people anxious so they can realize that normal anxiety response where they come down, it interferes with that because it's not allowing them to get anxious enough to, so they can experience the situation. Some anxiolytics, again, this is kind of debatable. Here, narcotics, pain meds, again, it's anything that's going to interfere with their ability to think through the material or to experience anxiety at the heightened levels that we need can interfere. Psychosis, full-blown schizophrenia, yeah, you probably don't want to do this treatment with people. However, there have been some cases where people have done it with, say, folks that are depressive with psychotic features. And we have found at the VA that CPT has been very effective because we challenge people's distorted beliefs. And so if some of their paranoid thinking is related to their trauma, or even if it's not, we challenge that and they can work through that. It's really helpful to reduce some of those symptoms as well. If you're going to do that, I would just caution you that you move slowly. You might have to extend the protocols and slow down a little bit just to work with the extra layer of mental health issues that the people are presenting. Severe cognitive impairment. If people are on the lower end of the average IQ scale, they can tolerate the treatment. If they're severely mentally retarded, probably not. So that's a contraindication. Alcohol and drug dependence. 2 reasons why that is not very effective. or that treatment isn't very effective for those people is because not only the avoidance mechanism that's going on, they're not dealing. A lot of the reason people do drink and use drugs is because they don't want to deal with events in their life or just life in general. So it really interferes with that. But also it causes brain changes and chemical changes in the brain, as y'all well know. So that can really interfere with the treatment. We typically will do treatment concurrent with alcohol and drug treatment at the VA. But we usually want them to start with the alcohol and drug treatment first, see how they do with that for about 30 to 60 days, depending on the individual, before we'll introduce the psychotherapy component. And then just high-risk behaviors. If you've got people that are suicidal and homicidal, you pretty much want to address that first before you get into the therapy. Make sure they've got some good coping mechanisms so when you do invoke the anxiety in them, they can handle it and they don't go back to these high-risk behaviors. I talked a lot about the treatment outcomes already. We do get a lot of reduction in depression and insomnia symptoms with these treatments. A lot of the research that came out of the PE folks saw no difference when medication was introduced. Research in other therapies shows the best outcome is when you combine therapy with medication. So if you have folks that are a little bit resistant to wanting to take medication, that's okay. We can still do the therapy and we can get them done quickly and they can still see some benefit. A lot of folks may not need medication depending on where they're at. Again, that's an individual thing. It's nothing to be generalized. But one of the main benefits of this treatment is it's time limited. Beginning, there's an endpoint. People know exactly what the sessions are going to entail. So they're not going to be getting treated for 3, 4, 5 years, the majority of folks. And it has minimal risk. The biggest risk that people face is their symptoms may increase for a little bit. Usually during the early phases of treatment, when we're starting to really tap into that shell of avoidance and break that down. But that's typically the worst thing that will happen. We haven't killed anybody yet, to my knowledge. We have a guy in one of our CPT groups a few years ago, and there was a little bit of concern that any kind of distress can put him over the top. We've actually had him stressed out in therapy a few times. He's done some relaxation skills. No adverse outcomes. So even with folks like that, they can get benefit. Again, you have to titrate it a little bit differently than with other folks, but it can be delivered and can be effective with all different kinds of patients. So I guess this is the thing with take-home points, but does anybody have any questions of either of us in terms of the pharmacotherapy or the psychotherapy? Sir?